So with these catheters, the cardiac output is always reliable, always accurate. The times that it's not accurate is when the thermal coil isn't sitting in the ventricle or isn't sitting in the correct portion of the heart. If the thermal coil, or the thermistor we'll say, gets past the pulmonic valve, that's when the temperature readings can be a little bit off, all right? So what we did to make this easier for you, and we're gonna look right here. You have an extra infusion port right here. You know that, you've used it before, the clear line. On this type of catheter, it exits at a different portion than what you're accustomed to. All right, this is also called a thermal positioning port. So you're used to it exiting more in this area. It's actually exiting now at the end of the thermal coil in the right ventricle. All right, so let's bring this all together. You're looking at your Philips monitor and you're transducing your PA pressure right now. You see a PA waveform. All right. Let's say you're coming on to your shift, and you know how you always zero your lines when you come on? This may also be something you want to get into the habit of doing. What you can do is take this stopcock, turn off the PA waveform, turn on, we'll call it the RV waveform, and what you should see happen on your monitor is you should then see that PA waveform flip to an RV. Okay, and that's telling you that catheter hasn't moved, sitting in the ventricle, because it's right at the end of the thermal coil. Now if you flip the stopcocks and the waveform doesn't change, what does that mean?
It has moved.
It's moved north, and you're gonna have to get the physician to back that catheter up. All right? This is a really nice piece for you guys. All right, I have to say, every group we've actually trained, they've really liked this piece because, look, yes, calling x-ray will definitely work. You can absolutely call x-ray, and you can definitely clearly see the thermal coil. But this is more instantaneous. This is, you can do this right on the shot and see exactly really where the catheter is sitting. All right, this is in the packaging with the PA. So you won't have to be searching for these. If for some reason they start coming up without them, tell me immediately, and also say something to the OR, or your catheters will be most likely being started in the cath lab. Okay. I met with Dr. Esteno about all of that today, actually. All right, that's it with the bridge. Does everyone understand that part? Just so you know too, in your policy, and actually
we'll still be able to use this.
Nothing to do with transducers per se. That's all done by your Philips, all done with, and that's us too. You're all done with Transpac. Okay, this had, just so you know, because some people kept asking, do we have to level the patient when we calibrate? It has nothing to do with it. Okay. And real quick, just to show you too, just so you can see the visual. That's where you're monitoring your PA pressure. That's where we want that distal positioning port to be, under the valve. Okay?
This will indicate no matter what position they are in, the cardiac output will be indicated. Is that what you're saying?
It'll be accurate if it's sitting in that portion. That's what I'm saying. Is that if you confirm that coil is sitting in the ventricle, I'll tell you that number is accurate.
Okay, got it.
Also, just so you know, in case you forget what I tell you, this image will be in your policy.
Okay.
Done with this is your thermal coil cable. This is what heats up, we'll say, that filament. Thermistor. Same thermistor cable that you guys are always used to. SVO2. All right? This is an optical line. Same thing like the fiber optic lines that Verizon uses and all those cable companies. They're very touchy. Same thing with this. You do not want to kink it. Okay, I'm not telling you you can't bend it like that, but if it's bent, you could bend the optics in here, and that number won't potentially show up, or it'll be off. And there's ways to, so just so you know too, again with the cardiac output, I've just told you the ways to check it. With the SVO2, when I go into it, there's ways that we tell you, or the monitor tells you, whether the number is accurate. All right?
Okay.
So if you're wondering why something's looking off, you'll have ways to look. So let me get the cables.
So we don't really have to do any more PA sats. It's already showing.
Yep, unless you're pulling from the PA for some other
no more
value.
Disconnection of any
No
sort.
more, nothing.
So that shall also.
Oh yeah,
that
oh
is
my gosh,
reusable.
absolutely. Woof, jeez. Woof.
Clorox wipe, right?
Yes, do not throw this out. My gosh, that's a $3,500 garbage can. All right, so these will just, you slide in, it says top on it. Slides right in, pop it over. Make sense? This connection goes there.
Yeah.
Look, I don't expect you to memorize these things. Is this gonna fit there?
But where is this monitor going to sit at?
Top of the Philips.
No, you'll have they're gonna be on they'll be on roll carts. Nice small roll carts. Brand new GCX roll carts that we paid for. So So this goes into O2, all right? Blue on blue, makes sense. Thermocoil, that goes in there. Again, this one's not gonna fit in any of these. And then this, which you guys have seen before, thermistor,
Yeah.
obviously will go where the
Oh,
square is,
okay.
not where the...
Okay.
You'd be surprised some of the questions I sometimes get. Like, where
Correct.
does this one connect? I'm like, I don't know.
But you do you necessarily have to connect this, or can we connect it to our own thing?
To your
No.
Phillips?
Yeah.
No.
All right, so I'll say it right now. Phillips has nothing to do with any of this. Ever, anymore, nothing.
Okay.
Okay?
got it.
Everything
so the
that you
temperature
do
goes in here.
goes through here.
Okay.
Okay? No more
The only
bricks.
thing we connect to the
pH
Phillips is the
pressures.
transducers.
The transducers
But the
still
PA
connect,
and
but
the
I'm
CVP.
yes,
Yeah, okay.
good and thank you. But I'm saying anything that has to do with SVO2, cardiac,
Cardiac
output,
and
always
temperature
is
of the
gonna
patient goes into
into
this.
here.
Okay.
Alrighty. And you'll see too, and I'm glad you brought that up. The temperature will be red
Okay.
right there,
Okay.
so you'll be able to see the internal time. And I run into this issue a lot where people think we're like a Philips patient monitor, so it's hard. You guys have so many different monitors too on top of things. So, and if any questions, boot up the monitor, all right, and put in all the connections.
Okay.
Right away.
Turn it on, yeah, right away. So let's say they're going to start one at the bedside. Boot up the monitor, hook it up, and let it run for 10 minutes. What you're doing is warming up the op mod. There's again, back to those fiber optic lines. They actually have to be warmed
Okay.
in here. Okay. You'll do that very first thing. Second thing you're going to do is take this. Remember, these are all plugged in right now. And you're going to connect it to this right here.
Brand new.
Brand new. All right. Keep in mind, this is still covered with your sterile sheath. This is not. We're not impacting the catheter. You're going to come over here, menu. All right. Menu is a pretty simple button. We'll say it's a standard one these days. And you're going to go to venous O2 calibration. Makes sense because that's what we're calibrating.
Okay.
So, clearly, we're doing a pre-insertion calibration prior to inserting the catheter. So what you're going to do is you're now running a calibration, and that calibration is checking that the catheter is sitting in that black box.
Okay.
This black box is a reference block. On the
Okay.
inside of it is something that's reflective, and the monitor knows exactly how reflective it is.
Okay.
That's how we calibrate the system when it's not in the patient.
Okay.
Okay? Confirmed, good. It's usually pretty quick to all of these steps.
Okay.
All right, so that's done. Now, prime your lines, get it ready, get the catheter in the patient.
Okay.
Good? Cool, keep going. Now you're gonna do the last part, light intensity baseline. Remember I brought up earlier about how the monitor is gonna tell you whether the numbers are good or not? Here's the image. So the light intensity baseline, all it's doing is checking that the blood is flowing past the tip of the catheter. What we're doing is sending out light and taking back the light and reading it on this. With the pulmonary artery, it's very branched, and there's a lot of small branches. The smaller branches don't have flowing blood per se. Sometimes it's more of a pooling type blood. That's what we're watching out for. We always want you to sit in a flowing blood, and your light intensity baseline is what checks that for you.
Okay.
All right.
This is not while it's still in here, or while
In the
it is
patient.
already
In the
in
patient.
the patient.
So this is after we calibrate it in the in the black box. We then get it all ready, get it in the patient, and then
Okay.
we do the light intensity.
Okay.
Okay. Now let's go over what's good. Green is clearly good. All right. Yellow, we're doing all right, but
Acceptable.
something's probably. I can tell you, if it goes from green to yellow, you get ready for it to eventually go to orange. That means something's eventually going to go wrong with it. So when you have it in this end, the low end, all right, that means pretty much three things. You have a kink somewhere in this optical line. So you just maybe massage it out, or someone may have really damaged it, and you have to put in a new line, which we hope doesn't happen. There's a clot sitting at the end of the catheter blocking the fiber optics, or there's fibrin buildup at the end of the catheter blocking the optics. Happens with all of these. Are very invasive lines. Fast flush with the PA. All right, that many times will clear it, and you can then go in, do another light intensity baseline, and you should see that immediately either come back to yellow or green. If it goes this direction, high, only one thing really does that. The catheter took a little turn and is now facing the tissue or the inside of the pulmonary artery. So it's not facing down at flowing blood, it's sitting right on a wall. Our insides, our tissue is very reflective. That's why it goes high. You see it in the middle, that's not good. It's not terrible, but it usually means that there's a failed component somewhere in here, or not usually the catheter, it's usually going to be in your op mod. So the first thing I would tell you to do, go get a new op mod, recalibrate it. A lot of times it's the op mod. Again, that's why I told you these are $3,500 a pop, and they're touchy. They're not breakable where, you know, if you do this, it's gonna break. But yeah, if you decide to drop it from here, it'll probably break. So, all right. That's pretty much it with the light intensity baseline. So what it's doing now is, again, so just so you saw, if you were watching per se, everything I do when you hit the green check is your confirm. That's your enter on the monitor. And then continue. And then our number shows up. All right, so you just calibrated the catheter before you stuck it in the patient. You did your light intensity baseline, it passed. Now that number you're looking at is exactly what the SVO2 is.
Okay. And that green right there is the same thing that we were just looking at, the light intensity baseline, right?
So it's always checking for you.
Okay.
It's always doing it. Here's the thing though, if you want to, it sounds, and I don't know, I'm gonna have to ask my clinical folks how they explain it, so maybe. You can always run a light intensity baseline if you're questioning the numbers. Or you can go in, and I'm gonna show you another way that we can recalibrate the system to get the numbers where you think they should be. There's going to be some times where you're going to look at a patient and the patient's having a full conversation with you and it says 35 and you're like, that's absolutely not right. Things happen with any technology. It's very rare that stuff happens, but hey, if you have the catheter in for 2 weeks, which is I think the standard here, by week 2, it's possible that so much buildup on the end is going to block some of the fiber optics. And I was speaking to Dr. Esteno about that today. All right. And again, that fast flushing will be a huge, immediate, hopefully, help with that.
Because if
So-
there is something at the tip of the catheter, it will.
Bingo. It'll hopefully
Flush
shoot
it
it
out.
out. Now let's go into, so again, to your question though, you will always see that it's always checking. So if you started to see it shifting left, you know that there could be a clot building up or someone's decided to bend something. It's going right, the catheter immediately turned. Okay? Now, let's give you, that was option 1, which is you start at the bedside. Option 2, they started in the cath lab and they send it up with nothing attached. Same thing, you're going to boot up the monitor and warm it up. That's what you always do. Should always be the standard. You're then going to go into in vivo calibration. In vivo.
In the
There we go.
patient is-
There we go. We tried to make it as self-explanatory as possible. It's immediately going to do a light intensity baseline for you automatically because that's what we need it to do. Because again, obviously the person floated it in and we know it's in the pulmonary artery. We're just making sure that it's sitting in flowing blood. So they're checking that right now. And while they're doing that, you can start to draw a lab. So you are going to draw for this one, you will draw a PA stat, all right, to calibrate it if it's already in the patient.
I mean, what do I mean draw? Like actually
Draw
Actually
lab.
draw
Draw
from
lab,
the,
yeah,
from the
from
patient,
the-
like what we
Yeah,
normally
just
do.
like you normally do.
Alright.
All right?
Can I clarify?
Yeah, no. Ask away, please. All right. Here's one thing too. You may see old data in here. So let's say you had a patient 2 days ago. Their SVO2, if you didn't clear it and put a new patient in, may come up.
Okay.
All right. That's not the end of the world. You'll just put in the new SVO2, and then when you're done, go in and change the patient information, please, so you know who you're monitoring. But we'll go in, enter the lab results. At 72 is in there. Let's say it came back as 80. I'm going to show you one thing when I go back to the screen. So I'm going to backtrack for 1 sec. Let's say that what I was telling you before. You're monitoring a patient, everything's hooked up, but the numbers don't look right to you. You're going to do this in vivo cal. It's not a bad thing to do, again, because you're checking really what the blood is. That mixed venous sitting right there. If it comes back, the lab, and it's within 4 percentage points of what the monitor's reading, you're not going to change the calibration because that means that the monitor's accurate. All right? It's on here. You don't need to memorize it. That's why I wanted to touch on it before I flip from this screen. Note, you see, retain previous cal if it's within
Okay,
4 points.
4%.
All right?
Is this 4%? 8 is not.
No.
No. So from there, you're then going to go through, again, back to check. Make sense?
Okay.
Any questions? Cool. So that to kind of retrack or backtrack on everything.
Okay, so in
Yeah.
vivo, you draw the blood and you enter, it automatically picks it up?
Yeah, it'll automatically bring you to that screen to then
Okay,
to
so
then
can
type
you
it
go back to that screen one
in.
more
Yeah,
time?
of course.
So in vivo, and then you did the blood,
You
okay.
hit start blood draw.
Okay.
It'll then cue you,
Uh-huh,
thinking you're drawing blood.
uh-huh.
Then it's going to flip in a sec. Flips.
Okay,
So
so
then
then,
from
you
here-
enter the lab.
There
okay.
you go. And then you can confirm more.
Okay.
So
Alright.
if it's off,
because it was 80 and
If it
78,
was,
so it's okay.
then it's okay. But if it came back as 86,
Then
change
you
the
enter.
calibration.
How do you change the calibration?
You just go into enter new cal and it'll
That's
come
it.
up.
Okay.
Alrighty.
That's what I wanted to know too, because that new number, when you enter, that's it.
Yeah.
You don't have
It's
to.
updating every 10 seconds. So you can watch the numbers flowing through to have an idea of what's going on with that patient. So, you know what's nice about this screen is, let's say you are doing a big drug titration. It's a good idea to maybe watch this because it'll update every 10 seconds. Alright, and you can see what's going on. This we won't go into, but if you click on it, to bivariant plot, this is more for when you and your team are doing studies. Alright, it's to compare hemodynamic or flow parameters. You can compare a bunch of different ones and create what we call a safety window. So like here, if you were doing a study and you were doing a new kind of drug and you wanted to compare the cardiac output, we'll say with this one to stroke volume variation, but you didn't want it to fall out of a certain area, and it would show you on the plot. Okay? You can do manual boluses through here, but we're not going to. And then the last,
What do you mean manual boluses for cardiac output?
yeah,
you
but
mean?
you won't need to. We're just saying that the monitor, you can hook it up and do a
Do a
bolus.
manual cardiac output itself. Is it iced? How does it accept? Is it
However
iced
you
or
want.
regular?
Yeah, gives you option. It doesn't matter because you guys won't do it.
Yeah,
Seriously.
but sometimes, once in a while, they're asking us to do. So I just want to know if there's.
Yeah, no worries. You have options right here. It'll tell you what, it'll pick up what you're doing, or you can change.
Oh, okay.
What-
So
what it
injectate
is.
temperature. If it is iced, then you enter the temperature.
Bingo.
Okay. So if it is normal, what is the temperature?